Yeah. Welcome all to the maternal medicine module, and we'll discuss the talk article skin eruption specific to the pregnancy. Okay. So in this talk article, we should know there are four important conditions, and there is a Ambrose Rudolph classification for these eruption. That is atopic eruption of pregnancy, then polymorphic eruption of pregnancy, pemphigoid gestationalis, and intrahepatic cholestasis of pregnancy. That is AEP, PEP, PG, and ICP. Okay, what happens in atopic eruption of pregnancy? Key feature is eczema prurigo. There is no fetal risk in this condition. The next one is a polymorphic eruption of pregnancy. Generally, it is associated with the striae and rash is there. Okay, but there is no fetal risk. The third one is little dangerous. It is associated with the pemphigoid and gestational. That is what we call it. It is an autoimmune blistering and associated with the IUGR. Do remember that there is a fetal risk with pemphigoid. Okay. Then next is a ICP. This also has got the fetal risk of stillbirth and other complications also. And there is a separate talk on the intrahepatic cholestasis of pregnancy. So we will go more into the details of this along with the GTG discussion. Okay. So in ICP, generally there is a itching without rash. Okay. Now, what are the physiological changes in pregnancy? And in this talk article, they can ask you questions, image-based question. They can give you the clinical scenario and image, and you may have to identify what is the diagnosis. Okay. So there are certain physiological skin changes which are happening. Most common is a pigmentation. Melasma is the commonest seen in 75% of cases. So this can also be asked as a SBA. The commonest physiological change in the pregnancy is the melasma, okay, in 75% of cases. Then other changes, linea nigra, areolar darkening, and this is mainly due to increase in the estrogen and increase in MSH levels. Okay. The gravidarum, that is another change. Okay, generally they are red in color, then they become purple, and finally they become hypopigmented scar. And this is mainly because of the dermal elastic fiber rupture. Okay, and this is because of the over distension. Okay, so this is the way this stria gravidarum will look like. Okay, then there are vascular changes such as spider nevi, palmar erythema, and this is mainly because of the increase in estrogen. Then there are hair changes. There's a generally during pregnancy, hairs may be increased because of the anagen phase is increased, while postpartum period there is a hair fall, and this is called as telogen effulvum, and this is seen around 3 to 6 months postpartum, and it gets recovered also. Okay, in the glands there are changes. There is increased sweating leading to miliaria. Then pruritus. Then there are changes in the gland. There is increased sweating, miliaria. Okay. The pruritus is commonly seen in around 18% of patients. Okay. So during the history, we should ask about the onset. What is the distribution? Is it associated with itching, atopy, drug history? That we should know. Then we should look for the symmetry. If it is symmetrical, most probably it is an endogenous cause. If it is asymmetry, that means it is an exogenous, likely to be exogenous. Okay. So what is the type of lesion, papule, vesicle, or bully formation? Because these typical descriptions will give us the clue for the diagnosis. Okay. So intrahepatic cholestasis of pregnancy, the key feature is that there is a severe itching. There is no primary rash. It will involve the palms and soles. It is worse at night, and secondary scratch marks can be seen. So this is the description which will be given in the scenario. If it is like description, you think of the ICP. So there is a severe itching, mainly in the night, affecting the palms and soles, and secondary scratch marks may be seen. Then fetal risk, what are the risks? One, there can be stillbirth, preterm labor, fetal distress, and meconium passage. These are the risks associated with the ICP. There is increased bile acid level and LFTs are raised. The management is by ursodeoxycholic acid. Antihistaminic can be applied, creams can be applied, and vitamin K role is controversial. Then delivery, there is no clear bile acid cutoff, individualized decision. However, regarding this, we will go further in detail as per the GTG we will go. Okay. There is a recurrence risk of 45 to 90% with this. Okay, ICP can recur in around 90% of patients. Okay, atopic eruption. The next one is atopic eruption of pregnancy. The look is like this. This is the image which is given in the talk article. It is the most common dermatosis. Early onset, generally in the first and second trimester, this is seen. There may be personal family history of atopy. The lesion is in form of papules or nodules affecting the face, neck, trunk, and extensor limbs. Fetal risk is not there. Management is by application of the emollients, topical steroids, antihistaminics. Then third is a polymorphic eruption of pregnancy. Okay, so AEP we have seen, ICP we have seen, then third one is a PEP. Okay, this PEP, polymorphic eruption of pregnancy, will be seen in the third trimester, more common in priming, starts in the stri, and there is a typical sparing of the umbilicus. And this is how we will differentiate this from other features and mainly from the pemphigus, because pemphigus will have the vesicular-bullous lesions and that will affect the umbilical area. While here in polymorphic eruption of pregnancy, there is a specifically sparing of the umbilical area. Okay, so lesions will be urticarial papules, which will form the plaques or later on, and they will spread to the trunk and thighs. The face is spared. Okay, while in pemphigoid, definitely the trunk and thighs will get affected, but it will begin in the umbilical region. While here the umbilical region is spared. Okay, then fetal risk is not there in polymorphic eruption of pregnancy. Topical steroid and the antihistamines is the treatment. Recurrence is not common. Next one is a pemphigoid gestationalis. Okay, PG. It is a rare autoimmune condition. It starts around the umbilicus and progress to form the blisters. Tense blisters will be formed. The diagnosis is by biopsy and immunofluorescence. Linear C3 deposition at the base membrane will be seen. There is a risk to the fetus. IUGR and preterm birth is known to happen. There is a 10% transient lesions seen in the neonates also. Treatment is topical or if required oral steroids, and in severe cases immunosuppressants may be required. Generally, this pemphigoid may get flare at around delivery, 75% of cases. Especially post-delivery flare is known to happen and recurs in the next pregnancy. Okay, and the severity may be more. So if you see this pemphigoid, these will be the bullous lesions, and this is the PEP where there is a sparing of the umbilicus. So if you get image-based, question, it will be helpful. So please go through these images also from the talk. Then how will you differentiate these all four features? Atopic eruption of pregnancy, polymorphic eruptions of pregnancy, then pemphigoid and ICP. Onset is early in atopy, while it is late in the polymorphic eruptions. It is in the second and third trimester in pemphigoid, and it is late in the ICP also. Rash is in form of papules in AEP, while it affects the stri in PEP. Blisters you see in the PG, while there is no rash in the ICP. Okay, umbilicus is not affected. Umbilicus is paired in PEP, while umbilicus is involved in the pemphigoid. Okay, itching is there in all, and it is severe itching in the ICP. Okay, and fetal risk with these two, pemphigoid and the ICP. Okay, while stillbirth is more common with the ICP. Okay. Now let us see the red flag conditions. So always look for this ICP and pemphigoid because they are known to cause complications in the fetus, and these definitely require the dermatology referral. Okay, and other cases like AEP and PP, when the initial management fails, then you refer the dermatology. While ICP and pemphigoid, if you diagnose, then you have to refer them. Okay, so unclear diagnosis and no response to treatment in other conditions. So while always refer ICP and pemphigoid gestations. Okay, so these are the things from this particular talk article. So itching without rash, ICP until proven otherwise. Stri plus umbilical sparing, it is PEP. Blisters, pemphigoid. Then most common is atopic eruptions. Worst fetal outcome is with ICP. Diagnostic immunofluorescence finding is a C3 deposition. Okay, and AEP in PEP, there is no fetal risk. Okay. So physiological skin changes, they may not ask, but these are the changes. Melasma, linea nigra, there can be areolar and genital pigmentation. These are the physiological changes which are happening in the body, and generally they are hormonally induced. So increased levels of estrogen, progesterone, MSH, these are responsible for this. So melasma is facial hyperpigmentation. It is seen in 75% of cases. It worsens with sunlight. So most commonly if they are asked, then it is a melasma. Okay. Then linea nigra under the hormonal stimulation, there is a midline abdominal pigmentation and it is common benign condition. There can be areolar and genital pigmentation also. Striae also, we know that striae gravidarum are there. This is mainly because of the rupture of the elastic dermal elastic fibers. They rupture and that is why you get the striae. Initially they are red in color, then they become purple, then they become hypopigmented. It is irreversible, but postpartum there is a generally fading. Okay, so there are vascular changes like a spider nevi, palmar erythema. These are the vascular changes. Then glandular hyperhidrosis can be there, miliaria can be there. So these physiological changes can happen during the pregnancy. So at the most, they can ask you about the melasma, that is the most common pigmentation change. Striae, it is mainly due to the dermal tearing and not just the stretching. Hair loss, postpartum telogen effulvum can be there. Spider nevi is estrogen mediated and pruritus, always rule out ICP. Okay. So when you have pruritus, when you have skin changes, you look for the pruritus, whether it is there or no. If it is there, if there is no pruritus, it may be physiological. If there is a pruritus, you think of the severity of the itching and whether the palms, soles, and are affected, and whether it is in the night. If it is these features are present, then you are dealing with ICP. Okay, then you have to do the LFT and bile acid. If there is itching is not severe, then you have to look for any primary lesion, what type of lesion you have. Okay, if you have the lesion, then you, what is the nature of the lesion, whether it is papules or nodules. Then if it is a papules or nodule, then it may be atopic eruption of pregnancy. If it is urticarial plaques, then it is a polymorphic eruption of pregnancy. If it is a vesicle or bully, then we are dealing with the pemphigoid. Okay, so these are the things which are there from SBA point of view. So itching without rash is ICP. Itching of the palms, soles, worse at night is ICP. Papules with history of atopy, AEP. Rash starts in the striae and spare umbilicus. It is a polymorphic eruption of pregnancy. Okay. Rash starts around the umbilicus and blister, pemphigoid. Okay. Most common dermatosis is atopic eruptions. Most dangerous is ICP. Which conditions will not have fetal risk? AEP and PEP does not have fetal risk. Okay. Autoimmune blistering is seen in pemphigoid. Diagnostic immunofluorescence, again pemphigoid. Treatment with ursodeoxycholic acid, ICP. Recurs commonly 45 to 90% cases, ICP. Okay. Recurrence worse in the next pregnancy, pemphigoid. Okay. Primary gravida plus late pregnancy rash is a PEP. So these are the things which are important from this. Okay. So finally, there is no rash but severe itching. It is an ICP. Striae involvement, it is a PEP. Umbilical involvement plus blister, pemphigoid, and atopy history, AEP. Okay. So that finishes the talk article on skin eruptions specific to the pregnancy. Thank you.